Good morning. My name is Camilo Molina. I'm a current chief resident at Johns Hopkins Hospital, and I'd like to thank Dr. Drozen and Dr. Johnson for inviting me to talk about something that I'm really excited here today about. I think we've heard these really fantastic talks all morning, and I think it's pretty well cemented that navigation is the future, and it's going to be part of pretty much every upcoming surgeon training, and the people who haven't used it before, I think they're going to want to catch up to the times and learn it, because it really is allowing surgeons to do things that we hadn't really thought to be possible before. We saw the talk in cervical spinal oncology, these incredible bony cuts that you're able to plan and navigate that you really could not do very safely before. And people thought they were, but they would get unplanned tumor transgressions and things like that. But now with accurate navigation, you really are able to do things that you weren't able to do before. And now there's emerging of robotics and navigation that's even making things potentially more accurate. So I think we're in a really exciting time. And so we're going to talk about something that was a research project that I started very early during my residency that led me to find Nissan, who's here today, as a startup company in Israel who were basically working on the same thing. I was thinking a little bit about outside the box on how we could take the standard cutting edge computer navigation that we had currently available, and how do we take it to the next level, how to avoid the pitfalls that we've heard about today. And the idea was to make a system that used augmented reality to implement the computer navigation that we use every day. So as a disclosure, I did eventually join the startup company. I'm the senior medical advisor at Augmented. And every person who's a surgeon in this room trained at some point without navigation, learned how to do freehand pedicle screws in thoracic, lumbar, not the cervical spine, at least not in America, except for C2, sometimes C7. But people are comfortable knowing that they could, if they absolutely had to, freehand pedicle screws, pretty much up and down the spine. We know how to look at the dorsal anatomical elements in the spine and merge that with what we see in a preoperative CT scan and be able to, get nice medial lateral and craniocaudal trajectories, by far and large, safely instrument the spine without the use of navigation. But, every once in a while, mistakes do happen, and these potentially can be catastrophic mistakes for the patient and for your surgical career. Significant medial breach of a thoracic spinal canal, patient's paralyzed, may have anterior breach, and you have a horrible vascular injury. And I think no matter how good of a surgeon you are, you could be made safer and better using navigation, because it's just an extra added layer of confidence, confirmation, and safety. And I think that that should not ever be disregarded as an opportunity to bring that into your operating room. So, I think we're familiar with what traditional manual computer navigation can give you. You have these, traditional windows where it shows you the medial lateral trajectory of your pedicle screw on the left there. On the middle, you see your sagittal trajectory. Actually, we see the same thing on the right, and you're able to, kind of place that screw wherever you truly really want it, get nice alignment, and do a good job. But as a disclaimer, at Hopkins, I like to think that up until very recently, we were in the medieval ages, because we were not navigating anything up until maybe 3 or 4 years ago. We didn't even have an O-arm until Nick Theodore came as the new spine director, and he brought the robot. He's actually one of the people who designed the Globus robot that we just saw a live demonstration. And he not only did he bring the robot that he basically invented, he also brought an O-arm, and then we started, thinking about how we could use these things. We started using it to navigate our spinal oncology cases or bony cuts, just like we heard earlier today. We started doing some MIS things. It really opened things up for us. But being an early adopter of this technology, one of the things that really didn't sit well with me is whenever we were using this, you were looking at a screen, and it didn't vibe very well, because that's how at least at the very beginning, when we did make mistakes using navigation, is because we weren't looking at the patient. We were focused on a screen, and the current computer navigation forces you to do that. You Google an image about computer navigation, and the first thing you'll see is the surgeons are looking at a screen and they're not looking at the patient. And I think that can set you up for a lot of errors. So, the idea was to take this current operating room model, which we've seen all day today. We've seen it in everybody's pictures. We saw it in all the live demonstrations, to people actually having navigation directly overlaid in front of their eyes. The same thing that we're familiar with, a 3D model that is 3D segmented from an intraoperative CT scan, and then use that as you traditionally would for a freehand placement to find your external anatomical landmarks, to pick an entry point as you would if you were freehanding, and then you get a nice axial and sagittal CT projection that you can use to get that nice medial lateral and sagittal trajectory. And that's all directly overlaid onto this head-mounted display. It's a directly head-mounted display. It has transparent lenses that have a direct retinal projection of all the navigation information directly into your visual field without having to take your attention away from the patient to look at an external monitor. We've heard all day about one of the major pitfalls and limitations and things that we haven't figured out completely, and some people are really good at it, but if they get their workflow correctly in terms of line of sight interruptions, where you set the eyes in the sky so that you don't have people, blocking your live navigation while you're placing the screw and things like that. I think we solved this problem by putting the tracking camera directly on the headset. So there really should be minimal to no line of sight interruption. What you're looking at, wherever your attention is focused, the camera is right there focused with you. So wherever your hands are doing, that you're watching your hands, the camera's watching your hands and it's watching the registration marker. So, when you use this, I hope you guys get to try it today. We have it in the cadaveric stations. You'll see that you'll have really no line of sight interruptions because there is no camera in the sky. It's all in the headset. We wanted to make it ergonomic. We thought about, if you develop something like this, it has to be lightweight enough and easy to wear enough so that people are going to wear it for an extended period of time. We wanted to make it wireless. We didn't want to have people tethered to an external, machine that they felt that their mobility in the operating room was limited. So we made it wireless, we made it ergonomic, it's battery powered, you can use it up to 3 hours and the batteries are exchangeable. So we thought a lot about the potential obstacles to implementing this and to have it be comfortable for the surgeons. And at least at this point, I think we've done a good job. It comes with the same things that we're familiar with, an external cart where you have someone managing whatever it is that you're navigating, maybe making sure that they're able to troubleshoot if the navigation is off or something like that, if they need to 3D segment the spine. This is the card that the wireless headset is wirelessly communicating with to give you the navigation that you need. And in terms of the navigation, we found that the NDI system, as we said, had the traditional eye in the sky model was not going to be good enough for us, because for that to communicate with the headset and the registration marker and the tools, it's created a lot of latency. And when you have something directly overlaid onto your visual field in an optic retinal display, your eyes are going to pick up any type of latency and it's going to be extremely uncomfortable. So out of that, we saw the necessity to develop our own navigational system. Completely proprietary, started from scratch, developed our own navigation system, where we just wanted all the registration markers and the navigated tools to be tracked directly by that camera on the headset. And through many iterations, we've made this extremely accurate, sub-millimeter positional accuracy. And then our software, immediately once you take that intraoperative CT scan, it's able to automatically 3D segment that spine, as people are used to, and then give you your nice axial and sagittal planes to optimize your screw trajectories. As of this moment, we wanted to make this potentially adoptable by, basically any surgeon, regardless of what their instrument and hardware preference is, whether they use Medtronic, K2M, Synthes, whatever it was. We wanted to make the usables, the instruments that we were going to bring in, very modular, so that we could navigate using this technology with any type of hardware. So, we have universal tool holders that really will fit any of the surgical tools that you want to use, whether it's a sonopet to guide your bony cuts for an oncological case, or whether it's, this company's, gear shift, or this, power drill for Stryker, whatever it is. We really thought a lot about designing universal tools. One of the things that I think we heard earlier, and I don't have a pointer, but this is kind of what a traditional spinous process clamp looks like. It grabs one spinous process. And, Dr. Kim asked the question in cervical spine navigation, how do you keep the spine from moving around a lot? It's so mobile. We actually designed our spinous process clamps to have this curvature to them so that when you grab a spinous process, you're actually not grabbing just one, you're grabbing 4 to 5. Depending on the size that you want, you can grab less. And that allows you to keep that spine very fixated while you're doing your, whatever it is that you're navigating, so that you keep your accuracy, because you're gonna lose accuracy because the spine is not a rigid body, and if you can't find a way to keep it still, your accuracy is not gonna be as good as you think, particularly in a place like the cervical spine, or if you're doing a trauma case and that you have a mechanical instability already from the get-go. That was something that I thought was a really big addition for us. So, what do I think are the big proposed benefits of what I think we're bringing to the table? Minimal to no line of sight interruption. Decreased learning curve. We've put this in front of some of particularly my attendings who don't do any spine or haven't instrumented, a spine in 20 years, and they're like, wow, this is so intuitive. It's like, it's right in front of you. One of the things that we talk about the learning curve, or they say we don't really he was saying that he doesn't let the residents do thoracic pedicle screws until they're PGY4s, because there's, in traditional computer navigation, there's something that I like to call the replication of inline maneuvers, right? So you have, he was saying too that, you memorize the initial trajectory where you cannulated a screw, and you have to kind of memorize that. So you go back in, especially if you're not using a K-wire, to find that exact trajectory. So you have to get a lot of good muscle memory at memorizing these inline maneuvers. And if you're shifting your attention in and out to watch a screen, I think it's a big learning curve to do that. So we found that when people are keeping their attention on the surgical field the entire time, that muscle memory to replicate that inline maneuver becomes a lot easier. You can learn that a lot faster. One of the things that I saw initially during the early adoption of computer navigation for us was that, people would go in and they would cannulate the pedicle, maybe tap it, and then they're ready for the screw, and they're like, oh, I think I need to medialize more, I think I need to lateralize more, and they were watching the screen, and they would drop their hand and medialize a little more, and the screw looked really good, but the person watching the spine was like, you didn't actually medialize the screw, what you did, you were just moving the spine. And so the thing tracking the NDI system, the camera in the sky that's tracking the navigation, thinks that you're now medializing that screw and it looks really good, or you're lateralizing it or whatever, but you're actually not moving the screw at all. You're just moving the spine. And then you take a post-operative CT scan. You're like, how did that screw end up like that? It looked perfect when I was doing it. It's because you weren't watching the patient. So the hope is that by keeping your attention the entire time on the surgical field, you're going to be able to minimize these type of avoidable errors. And then lastly, at this point, we're able to really be compatible with all the 3D image acquisition systems. If we get a DICOM, we can automatically 3D segment that. So we're hoping to be able to be implemented regardless of what it is that you're using, whether it's the BrainLab Aero, the Medtronic O-arm, the new 3D capable C-arms. We really want to be compatible with all these things because we want to be able to be easily integratable into whatever you're used to already in your workflow. So how have we done in terms of data? Are we any good? So our preclinical data or cadaveric work, this was actually before our even most recent kind of optimization of our in vitro accuracy, of our positional accuracy. This was before we even made the system better. We did a cadaveric study. It's pending peer review right now for publication. 5 cadavers, instrumented T6 to L5, 120 pedicle screws total. We used 2 different grading scales to grade our accuracy. The Gertzbein scale that probably most people are familiar with that grades the pedicle breaches, regardless of directionality, based on how big the pedicle breach is. So grade A, meaning the pedicle is completely not violated whatsoever. Grade B is 0 to 2 millimeter violation. Grade C 2 to 4. Grade D 4 to 6 millimeters, and grade E 6 millimeters. No directionality in terms of the grading, but just how much of a violation there was. And then, because we did want to think about, different, it matters if you violate something laterally versus something medially versus something anteriorly. One of the nice scales that exist out there is the Heery grading scale. So they like to grade the scale based on where the breach occurred. Is that? I don't know where that's. I'll pause for a second. That's perfect. Huh? Is that Dr. Johnson? Is it Cohen? All right, so in terms of the Heery grading scale, grade 1, again, very similar to the Gertz grading scale. There's absolutely no breach. At grade 2, there's a lateral breach, but the pedicle screw tip is still entirely within the vertebral body. A grade 3 breach, the screw tip breaches anteriorly or laterally. Grade 4 breach, probably one of the most potentially critical breaches, is a medial breach where you're potentially in the spinal canal, or an inferior pedicle breach where you're in the foramen and potentially causing a radicular injury, or a grade 5 breach where it's a breach that requires immediate revision, a completely transcanal breach or something like that. In this scale, people use it a lot in the literature, predominantly to grade thoracic pedicle screw placement. So when we use these scales, using the Heery scale for thoracic screws and the Gertz scale for lumbar screws, it's a busy slide, but average everything together, our accuracy for the thoracic screw placement was 97.1%, and our accuracy for the lumbar screw placement was 96%, and averaging those together for thoracolumbar screw placement, it was total 96.6% accuracy. If we do the entire accuracy grading just using the Gertz scale, we had 93.5% accuracy for thoracic screws, 96% accuracy for lumbar screws, for a mean total accuracy of 94.6%. And it's not perfect, but we went back and did a statistical analysis to compare how we did in terms of what's reported out there in the literature. One of the the biggest meta-analysis that I found was published with Eude et al. 10,418 thoracolumbar screws placed, and including both freehand and computer manual navigated screws. When they stratified their data, they had a mean accuracy for freehand of 89.3%, and different studies reporting a range from 74.9 to 99.3%. And for manual navigation, they had 96.6% mean with a range of 85 to 100%. Similarly, I found in one of the larger series that I found for robotic place screws, they didn't include the Globus robot. I was predominantly using the Mazer and the first iteration of it. 606 screws, 92.3% mean accuracy, ranging 84.9 to 100%. And when to not make a long story short, when we do the statistical analysis, we found that we were non-inferior to any of the data that was out there. So that was encouraging, but it wasn't yet perfect. We went back to the drawing board. We wanted to make our positional accuracy even better. And then we actually were approved by the Israeli Medical Board to actually do live clinical cases. So this is an image of the first live clinical use of this recently in Israel. And we've done now 3 cases live. So here, here's the data you can interpret for yourself. 3-level lumbar fusion, 100% accuracy, no pedicle breaches either medially or laterally or anteriorly. Nice trajectories, nice sagittal trajectories. Same thing for the second patient that we did, and same thing for the third patient that we did. So, our in vitro accuracy was not perfect. We thought, we went back, we made it better, and so far, our live clinical data, we're having 100% accuracy. So, what do I think of the potential applications? I think it's going to be phenomenal for minimally invasive cases, percutaneous instrumentation. It's going to be not only able to help you, place your screws, but, they asked earlier, can the robot help guide you to the facet complex and the disc space complex? Similarly, I think you're going to be able to intuitively use this to, plan your osteotomy cuts, plan your access to the disc space. And then I think it's going to be equally useful for not all, but many complex cases. I don't think I'll use it for all of my cases because, I come from a training where, we freehand so much, but there's so many instances where I think having some kind of additional navigation is going to be crucial. People with small atrophic pedicles, people with, significant coronal rotational deformities, tumor cases, planning osteotomy cots in spinal oncology, difficult cervical spine instrumentation. We heard a lot about that earlier. Cervical pedicle screws, transarticular screws, complex occipital cervical junction anatomy. And in terms of our future directions, we want to take this not just for spine. We do think that it has a lot of potential for cranial applications, particularly in stereotactic procedures, functional neurosurgery, hydrocephalus, brain biopsies, thermoablative procedures, image-guided vascular and oncologic lesion resections. And then we've actually, started to collaborate with people outside of, neurosurgery and orthopedic surgery to just do general orthopedic procedures and image-guided craniofacial procedures. And then, in case I didn't really do a good enough job of explaining the concept of what this is about, I have a small video to kind of show you what the workflow of this would look like. Play that video, please. I guess there's no sound, so you're gonna have to read the captions yourself. So that's the spinous process clamp that we're talking about. That curvature allows you to also be able to guide it in based on the patient's lumbar lordosis curvature and get it around multiple spinous processes, which I think is huge. I mean, I don't know if people who've used the traditional clamps, sometimes they break if a person's very osteoporotic. So that's another benefit. Being able to clamp multiple spinous processes at the same time allows you to kind of spread that force into multiple segments, so that not only you can keep those segments rigid, but avoid that very annoying, the spinous process just broke. Now we're going to put our clamp on. So it gives you that 3D segmentation, so you can pick your entry point, and then you can use the axial and sagittal projections to optimize your ideal, screw trajectory. We were talking about that virtual K-wires. We designed it so that you don't need a K-wire to avoid that potential pitfall of placing a K-wire in an unfortunate place. And lastly, thank you to the Seattle Science Foundation, Dr. Johnson and Dr. Drozen one more time for allowing me to be here today. The team and the entire team at Augmented, who've been incredibly fortunate to collaborate with Nissan, Tammy, and Stuart, and then Dr. Shuba, who couldn't make it here today. He's been my mentor, champion, one of my attendings who didn't think I was crazy when I told him that I wanted to do augmented reality computer navigation, and 4 or 5 years later, here we are. All right, thank you.
Any questions?
Yeah, so because the doctor is the only person wearing it, is there an additional screen that the doctor is able to show whoever's doing the operation, they're able to show what they see to say a resident for instructional purposes?
So actually 2 things. So we've configured the system so that both the operators can have a headset and the other operator can see exactly what the other person is doing. And it will be mirrored, so it's intuitive. It doesn't look like you're just watching what they're doing, but it doesn't make sense from your side. It's going to be mirrored, for one, and for two, there is that cart that has a large screen on it that anybody else who's watching the procedure externally can see what it is that they're doing. And you can see that today in the live demo.
I had a question sort of about the design. So the back of it looks like it is fully solid. Whereas I think a lot of female surgeons would have an issue wearing that for a long time, especially if they have to have their hair up. And if you're in a surgery for 3 hours, that's going to become a serious irritant to the surgeon. So I was wondering if there was a model or something where you had a bike helmet type gap for someone to have just a little room for their hair.
I gotta be honest, I hadn't thought about the female follicular anatomy in the design, but I'll take the good point.
I've had issues where there's a lot of pressure on the occiput. I've lost some alopecia right here, squeezing it too hard. So that is not just a female issue.
Yeah, well, we'll make sure that you don't squeeze your headset too hard.
You clearly squeezed it. Yeah.
Yeah, so that's a really good point. I've evaluated a couple similar technologies, and with both of those technologies, the weight of the headset was untenable for anything more than a 45-minute or hour operation. What's your weight target?
So to be honest, we designed it to be similar weight to in feel to the way that a headlight feels currently. In fact, we designed the headset initially with using the Integra kind of headlight model that most people are kind of who grow up through surgical training get used to wearing for the entire case. And you're not going to wear this the entire case. You're only going to wear it during certain parts of it that your instrument's in the spine. And then we designed the balance of it because there is some weight with the processor in the back of it. We designed that weight to be balanced by the interior part of the headset so that it's balanced appropriately so it's not very prominent. You don't feel it very much. And you'll get that sense today. That was a big part of the design, is how to balance that weight appropriately so that if it's balanced correctly, it doesn't pull you in one direction or the other.
So I just have a question regarding the reference clamp. So first of all, is it possible to work around the clamp, or what you're going to do when you fuse L2 to L5? Do you have to put it more thoracic, or?
No, the clamp, you can work around the clamp. The clamp can be very close to your field. When it closes down, it's very midline. It should not at all interrupt with the placement of your instrumentation, for one. And then for two, having the clamp in there, as we saw earlier, for checking the hex and what people do now, it's nice as a fixed landmark to make sure always that your registration and your navigation is still accurate. Because a lot of the problem with these systems is that they don't have a lot of redundancy, right? So when the pelvic pin gets misplaced or there's a phase shift, the surgeon doesn't always know it, and they continue working with this, false confidence that they're placing things correctly. So, if the system doesn't have built redundancy into it, you need to make the redundancy yourself and continually check to see if the things that are fixed are still lining up, just the way you were talking about with your little screws. And I think the Globus robot does a nice job of that because they have two reference frames, and if the reference frames move in relation to each other, the system knows that something's off, and that's what I think he was calling it. What did you call that part where the system tells you if you're a little off? I should know because I've used, yeah, skyvometer. But we have the Globus robot, so the robot will actually stop if it thinks that those two frames moved apart from each other. That redundancy, it turns yellow and it says that you can't continue until you fix whatever it is. So having that fixed clamp in the middle is crucial.
I'm going to stop the questions just because we have to keep moving on, and anybody else who has questions for him could catch them afterward. Thank you so much, Camilo.
Thank you.